Yeah, I'll start with that. So, there was a great session here at ID Week, and it was titled Evolving Hepatitis B Treatment Guidelines. And I think there were a couple of key points topically, but also brought up in the session. And the first is really that we are now recommending, or the CDC is now recommending, universal screening for hepatitis B. Remember, that happened for hepatitis C several years ago, but now we've updated that to now include hepatitis B testing. And that includes a triple panel test. So that's a surface antigen, core antibody, and surface antibody test. The other really important point to say is that in addition to universal screening, we're also now recommending universal vaccination, by and large, of hepatitis B. And those are new and I think really important for providers to be aware of, and something that was brought up in the session. Sue, do you want to talk about some new Hep B treatment guidelines?
Sure. I think it's great we talked about screening and vaccination. I think it's good for people to keep in mind that we have these WHO targets for hepatitis B elimination, that by 2030 we want to make some significant progress in terms of reducing Hep B as a public health threat. And we've got huge gaps, like only 13% of people with Hep B have ever been diagnosed, less than 3% are on treatment. So it's really important, these strategies, to do universal screening, universal vaccination to really help close those gaps. So for treatment, because we're at such a small amount of people who've been vaccinated, there's this who've been treated, that there is a push and need for us to really simplify the guidelines. And I think we're seeing that the guidelines were quite complex and very lab-based in terms of trying to phase people based on e-antigen, viral load, abnormal ALT, and a lot of people just never got to the point where they had actually gotten had all the tests and were being followed and being staged, and a lot of people were being lost to follow-up. And so we've seen guidelines shifting, and so there are a number of guidelines all around the world, and some of the very more recent ones have really made some significant progress in terms of simplifying. So I'll just use one example, is the guidelines actually from China, that were a combination of their liver and their infectious disease societies, where they're actually treating people with any viremia, so any detectable viral load, and abnormal ALT can be treated. And those who have normal ALT but detectable virus and are under the age of 30, over the age of 30, can be treated or have other risk factors. So that's just one example. The bigger guideline that just came out this year is actually the WHO guideline. And so that one actually has also, because it's geared for low middle income countries, in a lot of areas that have limited resources, don't have access to viral load, don't have access to specialists, they want to make sure people can have their Hep B treated even if they don't have they don't have a viral load test. So there are 4 points now in terms of being able to be considered eligible for treatment. So the first one is having fibrosis, which can be measured through blood work or through non-invasive testing like elastography. So if somebody has F2, any fibrosis, you don't need any blood work to qualify you for testing. So it doesn't matter if based on viral load or ALT, that alone, if you have fibrosis, you should be treated. The second one is if somebody has viral load of over 2,000 and any abnormal ALT. And this goes for ages 12 and above. So this is the first time that we're actually including adolescents into the treatment guidelines as well. And the third entry point is if you have any co-infection with HIV, Hep C or Delta, or risk factors such as family history or comorbidities such as diabetes, MASLD, or steatotic liver disease, or what used to be fatty liver, that those would be indications for treatment even without meeting those test thresholds of the viral load of 2,000. And then the last one is for areas that don't have Hep B DNA testing, which is much of Africa. A lot of areas in Southeast Asia and Latin America also don't have testing for viral load. That persistent ALT being abnormal is enough to start treatment for hepatitis B. So that's just kind of encapsulates some of the changes. There's some additional things with simplification and service delivery for WHO guidelines, but they are tremendous, good first step to kind of decentralizing care and closing those gaps of treatment.